In this episode, I will begin our discussion of some of the conditions associated with early pregnancy bleed, including conditions like GTD, spontaneous abortion, ectopic pregnancy, and we will continue with other conditions such as recurrent pregnancy loss and incompetent cervix. But in this episode, our focus will be gestational trophoblastic disease. First is a case of a pregnant woman at 16 weeks gestation with abnormal vaginal bleeding, and physical exam shows uterine size compatible with a 20 weeks gestation, while ultrasound confirms gestational age being 16 week, and beta HCG levels are more than expected for the age. What other clinical findings are expected in this woman? This is a gestational trophoblastic disease, and other possible findings include hyperthyroidism, hyperemesis gravidarum, preeclampsia with severe feature, and theca lutein cysts as bilateral adnexal mass. Please remember, this is one of the few conditions in which preeclampsia could occur prior to week 24. Now, what are the risk factors of molar pregnancy? Always remember extremes of pregnancy age. That's a woman who is pregnant at an age younger than 20 or older than 40. Previous history of molar pregnancy or gestational trophoblastic disease of any type, as well as deficiency of folate and vitamin A. What are the four types of gestational trophoblastic diseases? Complete or partial moles, which are the benign forms, as well as invasive mole and choriocarcinoma, which are the neoplastic types. How do we differentiate complete from partial mole? Based on mechanism that contributes to the karyotype, as well as the presence or absence of fetal tissue. Case, a previous woman that we introduced our case discussion with undergoes D&C after diagnosis of molar pregnancy, and the karyotype is 46XY. What type of molar pregnancy is this? First of all, remember that if the karyotype number is 46, we are dealing with complete mole, and if it is 69, we are dealing with partial mole, that is sometimes referred to as incomplete mole. Now, the mechanism of complete mole is fertilization of an ovum with inactive maternal chromosome by one or two sperm. Only if two sperms have been involved, we could have both X and Y chromosomes in a complete mole. Therefore, the mechanism of this case, molar pregnancy, is fertilization of an ovum with inactive maternal chromosome with two separate sperms, one 23X and the other is 23Y. If it was 46XX, we cannot say there were either one or two sperms that fertilized this inactive ovum, because one sperm can fertilize an inactive ovum and then undergoes duplication of paternal chromosome. Now, what is the possible karyotypes of a molar pregnancy in which fetal parts are present? The partial mole could have 69XXXXXY or XYY. There's always one X chromosome there, and the reason is why. It's because the partial molar pregnancy is due to fertilization of a normal ovum with two sperms. Now, in addition to the karyotype analysis, what other findings possible in the gross analysis of the D&C sample? Grossly, the uterine contents appear hydropic. That's edematous. What's the workup for the assessment of molar pregnancy in the cases we discussed? Of course, we initiate with pelvic exam, and the first test is ultrasound. What are the findings in the ultrasound? You may hear either the two typical terminology, that is snowstorm appearance or Swiss cheese appearance, or you may hear the technical description of the finding, and that is said to be a heterogeneous mass with anechoic cystic spaces, with the mass itself consisting of cystic hydropic villi. Now, what's the status of fetal pole or membranes or fluid? There is no fetal fall and there is no amniotic fluid presence in the ultrasound. In what level your HCG would be in molar pregnancy? It is usually in 100,000 range. That's 200,000, 300,000, 150,000, etc. A case for differential diagnosis challenge. We have a woman who has come to office for visit mentioning that her last menstrual period was 14 weeks ago. Pelvic exam in the first variant of this case is associated with a 17 weeks gestation, and beta HCG is elevated more than the evaluated, approved, or confirmed gestational age. What's the diagnosis? This is gestational trophoblastic disease. The second variant of this woman with early pregnancy bleed, that's pregnancy bleeding prior to week 20, is that even though she had her last menstrual period 15 weeks ago, the uterine size is smaller than that and beta HCG level is lower than expected for gestational age. What is the most likely diagnosis in this case? That is ectopic pregnancy. I'm just reviewing some differential diagnosis of a pelvic exam uterus that's larger than gestational age or smaller than gestational age. Remember the other differentials of larger uterus than gestational age, of course, multifetal gestation and polyhydramnios. Other possibilities are also leiomyomas and macrosomias. For the uterus smaller than gestational age, we have oligohydramnios and ectopic pregnancy, as well as fetus that is suffering from fetal growth restriction or is small for gestational age. Okay, after the initial workup with pelvic exam and ultrasound, what are the other assessment and workup tests to be performed in molar pregnancy? Chest x-ray, because of the possibility of what? The possibility of lung metastasis in the case of gestational trophoblastic neoplasias. Assessment of quantitative serial HCG, as well as DNC, dilatation and curettage, for both gross and histologic assessment. What's the management of molar pregnancy? Suction, curettage, and contraception for 6 months, plus weekly beta HCG assessment until the levels are undetectable. And this very last sentence blossoms into understanding and diagnosis of gestational trophoblastic neoplasias. What are the diagnostic scenarios or requirements for gestational trophoblastic neoplasia? While we discuss all those risk factors and findings associated with gestational trophoblastic disease, including the ultrasound and HCG findings, the precise criteria for GTN includes either serial HCG, that is measured in our follow-up on a weekly basis, fails to get undetectable in the 8-week weekly follow-up after DNC or suction curettage. So again, here the number is 8 weekly follow-ups. Or they become undetectable, but then in the second round of follow-up, which is 6 months with monthly follow-up, they become positive, even though they get undetectable initially. So let's review a case. A woman with the symptoms and diagnosis of gestational trophoblastic disease undergoes the 8-week weekly follow-up HCG assessment. Her HCG levels have been dropping but have not been undetectable by the end of 8-week period. What is the likely explanation? Pay attention to the fact that even though it is dropping, it has failed to become undetectable. So this woman needs further workup for the possible diagnosis of gestational trophoblastic neoplasia. This is one example of what is referred to as plateauing levels of the HCG. Remember, any scenario other than becoming undetectable by 8-week weekly follow-up and remaining undetectable after that for 6-month monthly follow-ups is considered positive for a chance of invasive gestational trophoblastic disease, or one of the 2 types of gestational trophoblastic neoplasia. Now, while the same risk factors apply also to the GTN, what are the more specific risk factors for the neoplastic type? One is advanced maternal age, not just younger than 20 years, but more commonly it is seen in advanced maternal age. The other is what type of hydatidiform mole is more commonly associated with the neoplastic type GTD, that is complete, but not partial, but complete molar pregnancy. Also remember that a presentation could differ from not only the things that we discussed, but also the symptoms of metastasis. That's the symptoms of complication. Also remember that it's possible for the initial focus to not be detectable, but the focus in the metastatic site be detectable. And the most common metastases, as I mentioned, are lung, but also remember CNS and vagina. Also, a type of metastasis that's possible is pulmonary embolism. That is, trophoblastic tissue embolizes to the pulmonary circuit. Let's continue our case for discussion of the management. If the case that we discussed in her follow-up has the beta HCG levels that plateau, the next step in the management is another attempt of suction curettage. That's false. Plateauing of beta HCG in the 8-week weekly follow-up indicates gestational trophoblastic neoplasia, and therefore we need to shift to the management of the invasive mole. What's the first step in the management? Pharmacotherapy with single agent chemotherapy. What are the agents? Methotrexate or the actinomycin. Which one is preferred? Methotrexate is preferred unless if contraindications are present. Continuing our case, methotrexate is initiated, and at the baseline of the treatment, the ultrasound also detects bilateral adnexal masses, which are cystic. True or false, the management at this step is hysterectomy. That is false. The bilateral adnexal mass in a patient with gestational trophoblastic disease indicates theca lutein cyst, and the treatment of gestational trophoblastic disease would address the treatment of theca lutein cyst, and they will disappear after the successful treatment. Simply put, theca lutein cysts are present due to increased levels of beta HCG. Now, we described the follow-up for benign mole. What is the rule of follow-up for the neoplastic type mole? Well, we have 3 possible scenarios. Again, remission if the beta HCG reaches normal level for 3 consecutive weeks. We have progressive or resistant disease if the beta HCG levels are plateauing or increasing. 2 final questions. One is for the choriocarcinoma. True or false? In the following case, a patient with chest pain and abnormal uterine bleeding 3 months after a normal uneventful pregnancy undergoes X-ray that detects multiple bilateral infiltrates. Beta HCG levels are also elevated. Again, true or false? CT of the chest, abdomen, and pelvis is required for this staging. That's false. Always remember the counterintuitive fact that chest X-ray is the method of staging for the lung metastasis of choriocarcinoma. And another final question is, if this patient undergoes treatment but there are residual symptoms after initiation of methotrexate, what is the treatment for this residual symptom? Hysterectomy. And this finishes our discussion of gestational trophoblastic disease.